Hi, this is Dr. Phil Smith, back again with part 3 of 8 on solving the MedRec problem, deconstructing medication reconciliation. Today I'm going to talk about disease and/or condition factors that impact the current medications that are used to do medication reconciliation. Again, a little bit about me that you can read on your own. So as we go through these 30 plus factors in these 8 parts, I want you to remember that this is just a partial list, and I'm going to be breaking these out in each of the parts. So last time I talked about the patient factors that you can see on this diagram, and today I've zoomed in on the disease and condition factors, and there are 5 of them as you can see listed. So first, I want to talk about comorbidities. And comorbidities mean other things about the patients or chronic illnesses or conditions the patients have that may impact medications through various mechanisms and need to be considered when we're doing medication changes and considering what new medications we're going to add, take away, or change dosages of. And when I get to comorbidities, I can break that into 3 major subsets. The first is cardiovascular conditions. The biggest one of these is really the congestive heart failure problem. And in cases where people have extreme, what we call systolic congestive heart failure, and they're in a phase of edema or swelling of the legs, they also may be having internal swelling of the intestinal system, which can slow absorption of medications. So even though a patient may tell you they're taking a medication, it actually may not be getting absorbed due to cardiovascular problems, either with edema or with a low cardiac output due to severe congestive heart failure or other similar cardiovascular conditions. A factor affecting 10% of the population is diabetes. Diabetes affects the microcirculation and can impact perfusion of and distribution of drugs, and certainly impact the kidneys and the liver as a secondary factor. And so diabetes often causes many problems with changes of the nervous system, in perception, and in that microvascular, as I mentioned before. So again, what you have written down as the current list of medications may not be the effective list of medications. Finally, we get into kidney and liver dysfunction. As I said, these could be a result of the other 2 problems, low circulation or diabetes microvessel disease, but kidney function can very much impact the elimination of drugs, as can the liver impact the metabolism of drugs. And so this can lead to toxicity and accumulation. And even though a dosage may appear to be a safe dosage, it actually may be causing overdosage relative to what the patient needs. So the current list of medications may not accurately reflect what's actually going on in the bloodstream with the level of medications in the person, and could impact your judgment in what new medications I should add or what dosage the person should be on. Finally, we have genetic traits. Some people are born with metabolic inborn errors of metabolism, such as G6 phosphatase enzyme deficiency, which is common in people born in the sub-Sahara part of Africa. People in the Mediterranean have certain defects that may be common, so you may not be properly metabolizing drugs themselves, or you may have protein errors which cause the amount of drug that's bound by your proteins to be different, and that can affect the relative levels of medications in your bloodstream, relative to what a person without these genetic traits or errors might have. Also, there are certain drugs we would not want to give to a person if they have genetic traits that may impact their metabolism of the drug after we administer it. So that wraps up the disease and condition factors. Next time in part 4, I will be discussing uh, errors that occur at the physician and provider level. And again, if you have not downloaded my free ebook called MedRec, Proposing a Solution for the Nightmare of Medication Reconciliation, here's the URL. See you next time.